Dear audience, welcome to the presentation of my 12-month progress report with my thesis titled Pharmacotherapy Considerations in Inflammaging. My name is Cosma Tudor Cristian. I'm part of the bilateral program which takes place both here in Budapest and back home in Iași. Peter, Ferdinand, Renata Pape, and Ionela Lacremera Șerban are part of my beautiful team, my beautiful coordinating team, and my trustworthy SMS is Amir Makoli. I came here with a vision that is to provide prolonged, healthy, and independent lives for the elderly. And to achieve this vision, our mission is to conduct research towards unveiling the role of common medication upon reducing the burden of inflammaging. These are the three specific goals, the three projects that I've started, two of them the last year and the last one in May 2025. And without further ado, let's jump straight into the first project, tightly related to my vision, that is investigating the effects of statins upon development of sarcopenia. A short presentation of 1 minute so that I don't bore you too much, and whoever is interested for more will listen to me for the next part. So, first of all, we all have heard about statin therapy. Well, statin-associated muscle pain or discomfort is a very well-documented side effect of this medication. Many patients who are recommended for cholesterol-lowering therapy are at an inherent risk of sarcopenia due to their age, first of all, and this medication further burdens and further accelerates sarcopenia development through a possible accelerated muscular breakdown and impaired muscle repair. Our study, of course, under the shade of populational heterogeneity, found that statins are safe, irrespective of comorbidities. This translates into the clinical practice through a wider array of patients benefiting from statin therapy and diminished concerns regarding their musculoskeletal status. Let's now start the real talk. So, sarcopenia is highly prevalent and is not just a term accompanying every description of over 60-year-old population. Actually, despite there are several definitions, as you can see in the figure, most of them rely upon three pillars. That is low muscle strength, low muscle quality, and low physical performance. These are mainly found in all definitions. But what is the connection between sarcopenia and statin therapy? Well, more than 20% of the population, especially elderly population, was recommended for treatment according to 2018 cholesterol guidelines, and this trend of ever-aging population is continuing. Also, there's a plethora of studies documenting the intense muscular side effects elicited by statins, and also a plethora of mechanisms underlying these effects. Therefore, it's our responsibility to find whether there is a significant association between continuous statin use and development of sarcopenia, or if statin use is limited to just some intense muscular symptoms. Therefore, the clinical question was elaborated upon a PECO framework, where the population of interest was adult patients. Exposure was statin treatment against not statin-treated patients, and outcomes revolved around biomarkers or physical traits in the sarcopenia spectrum. Our hypothesis is that treatment with statins is safe regarding the risk for sarcopenia. The search risk was elaborated upon two domains, the intervention including every statin still in use, and outcomes revolving around sarcopenia as a spectrum very wide. From 78 included articles, 63 were used in the meta-analysis process. This is the status of our project. We are in the risk of bias phase. And let's start with some plots. This is the plot representing 6-minute walk test of statin-treated patients against not statin-treated patients. 6-minute walk test is a very non-specific, straightforward test, which originally was designed for defining physical performance in either cardiovascular or pulmonary challenged patients. However, in recent years, meaning 2021 onwards, it has evolved into a very simple method of one of the pillars of sarcopenia. In this plot, you can see 13 different studies, 13 different populations from 13 different studies. Most are retrospective and prospective studies. In this before-after type of plot, you can see that the effect is a 28.96 meters in the favor of statin-treated group. being exactly between the average range of minimally clinically sound difference. Therefore, this plot demonstrates that statin-treated group leads to a beneficial effect that is clinically and statistically significant. Now subgrouping, and I show here only the chronic heart failure and COPD groups, we can see that irrespective of subgroups, chronic heart failure and COPD do benefit in a clinically significant way in chronic heart failure, but statistically significant in both groups. Moving now on to hand grip strength. Hand grip strength has been used as a sole indicator of upper body muscular performance, and some definitions actually recommend it as a sole measure for assessing sarcopenia, with cutoffs separated by sex, minimum 28 kilos in men and minimum 17.7 in women. Our plot shows that from 19 different populations, from 19 different studies, retrospective, prospective, and RCTs, the difference was a negligible 0.09 kilograms in the favor of statin-treated group. Grouping by major comorbidities, the apparently healthy population again shows a minimum increase of 0.5 kilos. Lastly, short physical performance battery, by grouping for major comorbidity, shows in totally a positive effect, as you can see by the almost 0.5 points in the favor of statin-treated group. Unfortunately, despite the mathematical significance, the way this SPPB parameter is measured does not allow us to consider it clinically significant, because SPPB score is assessed as an integer score, not a decimal score. Some strengths and limitations of this study. First of all, we identified some trends by subgrouping for major comorbidity. Our study reached a clinically significant result, at least in the before-after type of plot, in the only outcome, that is 6-minute walk test. And most important of all, this is the first meta-analysis on this topic. However, there are many limitations, so take these findings with a pinch of salt. There is a high populational heterogeneity, not only from the comorbidity aspect, but also from the age and other medications that, unfortunately, most studies didn't report. There's a high risk of biased baseline, which is explained by the things I previously mentioned. And most importantly, and I think this should go to guidelines, there's a high inconsistency in performing those physical measurements which actually defined sarcopenia outcomes. Small conclusions. Major comorbidities, generally, do not adversely impact safety of statin treatment. We can say that statin treatment is not unsafe, irregardless of comorbidities. And walk performance was positively impacted in a clinically significant fashion in the statin-treated group. Translating to practice, statin therapy can be prescribed with almost no reluctance with respect to comorbidities, and most importantly, all physicians need to familiarize with sarcopenia diagnostic procedures and should longitudinally track their patients' progress. Research-wise, there's a high need for standardized sarcopenia diagnostic test procedures, and we need to better characterize major satellite, meaning ongoing comorbidities. Just introducing my second project, which is in the preliminary phases, is titled Assessment of the Efficacy and Safety of New Antidiabetic Drugs Upon Improvement of Inflammatory Profile. So by 2021, more than 500 million people were affected of diabetes, and this number is expected to rise to 1.3 billion by 2050. The majority of these people are in the higher brackets of age, so at this advanced age, cardiovascular protection should be focused upon mitigating inflammation. Inflammation which the anti-inflammatory actions of several antidiabetic drugs funnel together into an inhibition of the activation of NF-κB, aspect which is consistently demonstrated by a lower activity of C-reactive protein and TNF-alpha. Acting upon several sites inside the cell, these antidiabetics actually prove beneficial for the diabetic patient. Therefore, finding the best medication in this regard will ensure the best standard of care for the patient. To sum up, again, these are the three projects which I plan to submit over the course of this and the next 2 years. And I would like to end my presentation with my favorite quote: "The road to success is always under construction." Thank you.
Congrats, Tudor, on your presentation. I think you did a great job with this project. I was wondering, you said on the PICO slide, you mentioned also the biomarkers as an outcome. Yes. But did you find data on those, or they are not significant, and that's why you didn't present anything about this part?
This is an exceptional question, and one which I think I should have developed more. One of the biomarkers we were interested in was appendicular skeletal mass or appendicular lean mass. These are determined through DEXA measures. However, due to the low availability of this type of measuring, only 2 articles actually reported something, so we couldn't pull anything, so those parameters ended up in the systematic review part. But yes, and also some newer articles, 2024 and onwards, actually mentioned the need for more accurate determinations such as DEXA and the need for availability of this measure across a wider array of practices. Thank you.
Thank you.
Thank you for your presentation. It was great, as always. As one of your co-investigators, we have talked a lot about this topic, but I have never asked you, when you started this topic, did you have, and if you did, then what was your preconception and suggestion about the topic? And did it change or not, or what now?
So my expectancies around this topic was that statins are safe. As you saw in the plots, only one parameter, that is 6-minute walk test in the before-after, so on a longitudinal scale, proved not only to be safe, but also to be beneficial. That's why, as I said in the conclusions part, we cannot really draw the safety aspect so clearly. Firstly, because of heterogeneity, but also because statin treatment does not consistently lead to a beneficial effect. That's why one of the conclusions that I want to draw attention to is that statin treatment seems, under the shade of heterogeneity, to not be unsafe. I hope I answered your question.
Thank you for the very entertaining presentation. My question would be, well, first a short question. Are you affiliated with any pharmaceutical company?
No.
Okay, okay.
No.
So you are not developing.
It's not a bias.
Okay, okay. And then the more I listen to you, the more it becomes clear that do athletes take statins, or is it already on the list of forbidden substances? Because it looks like it improves sport performance.
It's very interesting.
Should it be considered for improving performance?
There is a single article, we didn't include it here because the way they measured physical performance was 1 kilometer walk and 1 kilometer run. So yes, they tested it in athletes, and that article actually reported that it is beneficial, especially after an intense cardiovascular workout before the test was performed. So if the athlete was well rested, statin administration for a very short duration, that is 2 pills before the test, let's say, did not lead to a significant effect. However, if the athlete was tired, statin treatment improved against not statin treated athletes, which is kind of contradicting with statin elicited muscular effects, because if there is a muscular tiredness, statin should lead to muscular pain. However, in athletes, and athletes I'm not referring to 18 years old, they administered up to 65 years old, and it led to a beneficial effect.
Thank you. That's a very interesting topic, and I grabbed the opportunity to ask a question. Sure. Statins are taken long term, so the 2 pills are basically yes. A kind of yes. unique experience. And of course, with aging, sarcopenia gets worse. Yes. So if you would have eventually potential for subgrouping for like length, dose, okay. type, and basically the age, well, it seems the 6-minute walk is usually applied in elderly people,
Yes.
like not athletes. So very
Yes.
likely it was done in elderly
Yes.
people. But the dose and the type would be also very interesting questions.
Yes, thank you for the question. It's a very nice thing to talk about. I will limit because I see the time. So, first of all, we looked for the dose, type of statin, duration of treatment. Only 4 articles reported duration of treatment out of 78. Of course, we exclude RCTs because RCTs are administered over a certain period of time. But outside RCTs, most articles either reported continuous statin treatment for at least 3 months or continuous statin treatment for at least 12 months. So we couldn't really group upon duration of treatment, even less upon dosage, even less upon type. However, we have started a prospective registry back home in Iași, where we would include major comorbidities, other medication, because some medication does impact sarcopenia development, and also type, dosage, time of statin treatment. So yes, it's an ongoing study. Hope to see some results.